Major depressive disorder, or MDD, is a heterogeneous disorder and one of the leading causes of disability worldwide. According to the World Health Organization, over 264 million people of all ages suffer from light, moderate, or severe depression. Although a broad definition, there are clear distinctions between depressions with and without psychophysiological precipitating events. These changes can encompass disturbances in sleep, appetite, and libido, loss of ability to experience pleasure, crying, suicidal thoughts, and slowing of speech and action. Diagnosis of this disorder requires ruling out pre-existing mental and health conditions, and the symptoms must be present for 2 weeks or more, and patients will likely meet 5 out of 9 diagnostic criteria, namely depressed moods, apathy, and lethargy. Although affecting many worldwide, MDD is twice more common in women than in men, and whilst the average age of onset is in adolescence, it often follows a recurrent course, first peaking at 25 to 30 years old, followed by a second peak between 50 to 60 years old. MDD can be divided into 4 major subtypes: postpartum depression, melancholic depressions, atypical depression, and dysthymia. Depression in itself is a disorder with a highly variable course, inconsistent responses to treatment, and no established mechanism. This exemplifies that major depressive disorder is not caused by a single gene mutation, but is a disease with complex polygenic features and different methods of expression. There are many different treatments available for moderate to severe depression, such as psychological treatments, cognitive behavioral therapy, or antidepressant medications such as SSRIs or TCAs. However, it can be seen that depression manifests itself in the body as a hypersensitivity of the hypothalamic pituitary adrenal axis. This will be further explained by Aleisha speaking on the genetics of MDD. This abnormality can increase the risk of MDD if paired with other neurological conditions such as stroke, Parkinson's disease, multiple sclerosis, and postpartum depression, as well as other social factors that can exacerbate this disorder. We will be speaking about the endogenous and exogenous factors that can lead to MDD, as seen in the outline of our presentation.
Endogenous polygenic factors pose a risk for individuals with MDD. Studies show the offspring of depressed compared to non-affected parents have an elevated risk of developing depression. Postmortem studies show decreased function of the serotonergic mood system. A genetic variant of the 5-HT1A receptor, particularly the C101-9G promoter polymorphism, was prevalent. A family-based study found that 2 non-synonymous SNPs altered the coding sequence of the 5-HTT gene, resulting in variations in the associate receptor. Similarly, this candidate gene coding for serotonin was examined in animal findings, where an allele variation located on the 5' region of chromosome 17q was prevalent in a heterozygous study of mice, in which these disrupted genes instigated fearful behavior and an increase in ACTH. The hyperactivity of the HPA axis is the most uniform neuroendocrine abnormality in depression. Recent hypothetical impairments of axis regulation in combination with increased cortisol concentrations were examined. Deficits in the GR receptor and CRH have posed specific allele polymorphisms involved in HPA dysfunction. A recent family study examined the downregulation of the NR3C1 gene, which led to decreased cortisol sensitivity due to futile feedback control. This resulted in reduced affinity of CRH coding factors, leading to failed termination of cortisol discharge. Finally, it was proposed that DNA methylation to an epigenetic sequence predisposes MDD patients. Specifically, the DNA M loci of the NR3C1 gene and FKBP5 gene were linked to stress activity. The methylation of the CpG enhancer sites was based on a variant interaction with individuals being carriers of the risk allele. With both these genes being regulators of the HPA axis, studies show persistent overexpression leading to a failed stress termination response. Next, Maggie will discuss these endogenous interactions.
Alyssa before me has mentioned how endogenous factors can affect multiple heterozygous elements. He'll explain how those factors are linked with endocrine function. MDD can be divided into various subtypes. Within these subtypes, the HPA axis can react differently. For example, melancholic depression can be linked with increased HPA axis activity, while atypical depression is linked with a decreased level of HPA axis activity. However, most cases of MDD are associated with reduced level of monoamine neurotransmitter, such as serotonin, noradrenaline, and dopamine, which regulates mood, appetite, and sleep. Neurons that produce serotonin are primarily located in the brainstem, in a cluster of neurons called the graphene nuclei. The axon of these neurons then project outwards, bringing serotonin all around the CNS. When there's a stress stimulus, the HPA axis is activated minutes after the adrenal surge. First, starting with the secretion of CRH in the hypothalamus, which then stimulates the synthesis of ACTH by the pituitary. The ACTH then stimulates the synthesis of cortisol in the adrenal cortex. The key role of cortisol is to maintain the homeostasis in response to stress. Without the proper function of this, leads to many psychotic disorder. Patients with MDD are often associated with low levels of serotonin. As mentioned by Alyssa, this can be due to a variant of the 5-HTT gene, causing abnormality in the 5-H1A receptor. Therefore, serotonin are unable to bind to the receptor. It can be caused by an increased concentration of cortisol in their plasma, urine, and CSF, hypersecretion of CRH, impairment in response to glucocorticoids, and increased size and activity of the pituitary and adrenal gland. Aashna will now follow up with exogenous factors.
MDD development can also be influenced by exogenous factors, in other words, materials that develop from outside the organism. Increased risk of MDD has been correlated with social factors, particularly prevalent in individuals who face psychological stress and trauma and learned helplessness. Psychological stress and trauma incorporates acute psychological trauma, moderate chronic stresses, and early exposure to childhood trauma. Hosang and others conducted a study of people suffering from major depression, finding that in the 6 months prior to their worst depressive episode, that they were exposed to several significant stresses, such as serious injury, illness, or assault, death of a loved one, separation of a steady relationship, job loss, or major financial crisis. The presence of psychological stress and trauma strongly increases the risk of developing MDD. More specifically, these aspects are associated with the sensitization of neuroendocrine and autonomic systems in response to stress. These findings were present in both animal and human models, in which non-depressed subjects were subject to emotions of chronic stress and trauma. These studies indicated an increase in the expression of inflammatory markers, including TNFs, IL-6, and CRPs. Therefore, psychological trauma significantly exacerbates the inflammatory and immune response, thereby increasing the risk of the development of MDD. Depression has also been associated with learned helplessness, which refers to avoidance learned as a result of repeated exposure to non-contingent stimuli. Consequently, these experiences are linked to symptoms of depression, including hopelessness, low motivation, and low self-esteem. Similar to the studies of psychological trauma, this has been accentuated in both animal and human models. When non-depressed subjects were exposed to feelings of learned helplessness, the subjects experienced elevated levels of cortisol, an increased presence of systemic and CNS inflammatory markers, including TNF-A, IL-6, COX-2, and toll-like receptors. By paralleling the symptoms of depression in models, these studies support the learned helplessness model of depression.
It is important to note the role of the HPA axis in regulation and mediation of the stress and inflammatory response. MDD is a condition that has been found to influence bodily function, such as neurotransmitter imbalances and HPA disturbances. Psychological trauma, one of the factors, has been associated with increased CRH activity, in which high Met al. Reported that women with a history of child abuse and major depression showed significantly increased cortisol responses and a blunted ACTH response to psychological stress. The life cycle stage plays a key role in the severity of MDD, more specifically childhood trauma, which has been found to heavily impair the HPA axis. The sensitivity of the HPA axis can primarily be seen during the infancy stage, where exposure to stress can lead to long-term dysregulation, such as increased sensitivity to future stresses. This is evident in the fact that the HPA axis is socially regulated and hyperresponsive by the age of 1. Studies conducted on rats, which have similar hormonal responses to humans, found that maternal separation caused dysregulation of HPA regulating receptors, ultimately causing hypersensitivity in their stress response and internalized behavior. Therefore, during the crucial stage of HPA development, infancy, traumatic events may cause improper development. Rats who were separated from their mother for just 1 hour had an increased release of corticosterone. Despite this evidence, there has been no study conducted to examine how age may affect different HPA axis indices in the same sample. Rather than relying on one study, multiple investigations have been used to determine the aspect of the HPA axis that is dysregulated. Dysregulation caused by these factors are responsible for incorrect and inadequate hormonal and neural responses, leading to abnormal stress coping mechanisms, ultimately causing increased susceptibility to MDD.
In summary, we know the etiology of the major depressive disorder is multifactorial, encompassing social and genetic influences. The most important exogenous factor we've identified is the stress stimulus, which promotes the secretion of CRH from the hypothalamus, triggering the cascade of processes involved in the HPA axis, leading to the production of cortisol. In the case of MDD, there is inhibition of negative feedback by the glucocorticoids to suppress the secretion of CRH, leading to a hyperactivity of the HPA system. In addition to exogenous factors, polymorphic variations in genes may be involved in impaired HPA axis feedback. The genes most likely to be involved are those that encode the targets of cortisol and other glucocorticoid hormones secreted during stress. In particular, we have identified these important gene variants that interfere with the HPA axis. We know that external stresses from critical life cycle stages, including prenatal, postnatal, and early life, can all modulate the pattern of DNA methylation. Hence, epigenetic mechanisms may also be involved, causing changes in different neurostructures and their functions. These functional and structural alterations induce the biological changes that are translated into the hyperactivity of the HPA system upon exposure to external stresses, stimulating increased levels of CRH and cortisol. Such changes also affect monoamine transmission, manifesting as changes such as decreased serotonin levels, resulting in emotional changes that also predispose individuals to MDD. Therefore, our central message is that MDD is a heterogeneous disorder. Various vulnerability factors that range from biological, genetic, and social aspects can all interact with external stresses at pivotal life cycle stages, in turn interfering with endocrine functioning such as the HPA axis. The heterogeneous nature results in variability in how individuals respond to stresses and predispose the affected individuals to the development of MDD.